Welcome to the deep dive. We're here to take all that dense, specialized source material, the complex anatomy, the physiology, and really distill it down into practical, high-yield knowledge for you.
Exactly. Today, we're focusing on the human heart. But not just a basic overview. We're digging into its structural secrets, its location, its size, its microscopic makeup, and connecting that directly to, to clinical practice. Why things go wrong where they do.
Right. It's about understanding the heart as this incredible, high-performance machine, a sort of asymmetrical dual pump.
Yeah.
And I guess the first thing, structurally, is where it actually sits. Its orientation.
Yes, that's crucial. The big picture is the heart isn't centered neatly. It's oblique. Tilted, you could say, inside the middle mediastinum. Think of it leaning quite heavily over to the left.
Okay.
The sources are clear. About 2/3 of the heart mass is left of the midline. Only about 1/3 sits to the right.
Like it's sort of wedged in there at an angle. And that angle, that tilt, means different parts face different directions, which, as you said, has big implications. But let's start with size. The classic comparison is your fist.
Yeah, and that's actually a pretty good rule of thumb.
Right.
Surprisingly accurate for a quick estimate. But if we want specifics, for adults, we're generally looking at around 12 centimeters long, maybe 9 wide, and 6 deep.
Okay.
And the weight, that's a really key clinical marker.
The sources mention a difference between sexes, often related to body size, I suppose.
That's right. An average adult male heart is about 300 grams. For females, it's usually a bit lighter, maybe around 250 grams. But the number to really flag in your mind is 400 grams.
The threshold.
Yeah. Exceeding 400 grams is generally considered pathological cardiomegaly and enlarged heart. When a clinician sees that, they're immediately thinking about chronic stress, like maybe severe high blood pressure or valve problems making the heart work way too hard for too long.
Wow, okay. So that tilt, that 2/3 left rule.
Yeah.
Let's connect that to the surfaces. Which part faces forward? Which faces back?
Yeah.
Because that determines vulnerability.
Precisely. Let's talk about the front surface, the one right behind your sternum and ribs. Anatomically, we call it the sternocostal surface, and because of that tilt we mentioned. This surface is formed mostly by the right ventricle, the RV. It's sitting right there, front and center, almost like a buffer.
So if there's trauma to the front of the chest.
Exactly. Proximity equals risk. The clinical takeaway is pretty stark. The right ventricle, being the most anterior chamber, is the one most likely to be injured in penetrating chest trauma. Think stab wounds, for example.
Right.
If someone comes in with a wound to the front of the chest, damage to the RV is often the immediate life-threatening concern. And here's the tricky part. Because the RV is a lower pressure chamber compared to the left side, a wound there might temporarily seal itself off, a phenomenon called tamponade. It can mask how severe the injury really is initially.
That's dangerous. Okay, so RV is up front. Let's flip around to the back. The posterior surface or the base of the heart.
Right, the base. This is formed mostly by the left atrium, the LA, and its position is really critical because it sits directly in front of the esophagus, the tube you swallow food down. It's nestled right between the heart and the spine.
We'll definitely circle back to why that's important later, I imagine.
Absolutely. Huge clinical relevance there.
Okay, and then the pointy bit at the bottom, the apex.
Ah, yes, the apex.
Yeah.
That's formed by the powerhouse, the left ventricle, the LV. And for those listening, you can often feel its beat, the apical impulse. Usually it's in the 5th intercostal space, kind of in line with the middle of your clavicle.
And does that move?
It can, yes. If a patient develops left ventricular hypertrophy, maybe from chronic hypertension, making the LV muscle thicken up, that apex beat actually shifts. It moves downward and more to the left. It's a classic, simple bedside sign that the LV is under serious strain.
Fascinating. Okay, let's zoom in now. From the big picture, the geography, down to the cellular level. The heart muscle itself. It's not quite like skeletal muscle, is it?
Not at all. We're talking about cardiac myocytes. They are striated, like skeletal muscle, yes, but they're also branched and typically have just one nucleus per cell. But the real magic, the key to the heart's continuous work, is how these cells are interconnected.
The sources use this term functional syncytium. Sounds like a unified power grid.
That's a great way to think about it. A syncytium means all these individual cells act together as if they were one giant cell. They're linked electrically and mechanically. And this coordination is absolutely vital for an effective pump. The structure that makes this possible is called the intercalated disc.
Right, and the notes broke this down. The intercalated disc isn't just one thing. It's like 3 specialized components working together.
Exactly. Think of it like a super specialized junction box. It needs to handle electrical signals and intense physical force.
So component one, what does it do?
First, you have the gap junctions. These are essentially electrical connections, little tunnels allowing ions to flow directly and very quickly between cells. That's the electrical coupling. It ensures the wave of depolarization spreads almost instantly, so all the cells contract in near-perfect synchrony.
Okay, the electrical wiring. What about holding it all together under pressure?
That's where desmosomes come in. They act like strong rivets or spot welds, anchoring the cells together mechanically. They prevent the tissue from tearing apart during the forceful contractions of systole.
Makes sense. And the third piece, transmitting the actual pull.
That would be the fascia adherens. These structures anchor the actin filaments, the contractile fibers within the muscle cell, to the cell membrane, and they transmit the force of contraction from one cell to the next. So these three together gap junctions, desmosomes, fascia adherens, allow the heart to function as this single powerful unit.
Incredible engineering. But the actual trigger for contraction, the excitation-contraction coupling, that's
Yeah.
also different from skeletal muscle, particularly regarding calcium.
Absolutely fundamental difference. Skeletal muscle gets most of its calcium from internal stores. Cardiac muscle, however, crucially depends on a small initial amount of calcium entering the cell from outside through specialized channels called L-type calcium channels.
Just a tiny bit from the outside triggers it.
Yes, exactly. That initial small influx of calcium acts as a trigger. It then causes a much, much larger release of calcium from internal stores within the cell, the sarcoplasmic reticulum. We call this amplification process calcium-induced calcium release, or CICR.
Ah, CICR.
Right, and this dependence on extracellular calcium is key for regulating heart contractility. It's also why many heart medications, like calcium channel blockers, target these specific L-type channels.
Okay, let's shift gears slightly to the plumbing. The really big pipes connected to the heart, the great vessels. The aorta and the pulmonary trunk don't just sit side by side, do they? They cross over.
They do, in a very specific spiral pattern. This crossing is essential for ensuring oxygenated blood goes to the body via the aorta, and deoxygenated blood goes to the lungs via the pulmonary trunk. And, for anyone looking at medical images like a CT scan of the chest, understanding that arrangement is vital. There's actually a helpful mnemonic for sorting out the major vessels around the level of the aortic arch.
Oh, I saw this in the notes, the RAT mnemonic. Tell us about that.
Okay, think RAT on a cross-sectional view. On the right, you'll typically see the superior vena cava, the SVC. The aorta is generally to the left. And the trachea, the windpipe, is usually in the middle or slightly posterior. RAT, SVC, aorta, trachea.
So RAT, right, is SVC, aorta left, trachea middle. That's actually really useful for orientation.
It helps get your bearings quickly on imaging.
Okay, let's move to the heart's own blood supply now, the coronary arteries. And this leads us to something really counterintuitive, a point that's fundamental to understanding heart attacks and ischemia.
Yes.
The coronary arteries, which branch right off the aorta, they fill mainly during diastole, the heart's relaxation phase, not during systole, the contraction phase.
This is such a critical point. It seems backwards, but think about it. During systole, the powerful contraction of the left ventricle squeezes down hard on the coronary vessels running within the heart muscle itself.
Like stepping on a garden hose.
Exactly. Intramyocardial pressure skyrockets, effectively shutting off or drastically reducing flow. It's only when the heart muscle relaxes during diastole that the pressure within the muscle drops, the vessels open up, and blood can surge from the aorta into the coronaries, feeding the heart muscle. The heart nourishes itself during its rest period.
So what happens then if the heart rate gets really fast? Tachycardia. You're cutting down that rest period. Right?
Precisely. That's the inherent vulnerability.
Yeah.
In severe tachycardia, the time spent in diastole shrinks dramatically, since that diastolic period is the primary window for coronary filling. A very fast heart rate literally reduces the time available for the heart to get its own oxygen and nutrients. This can lead directly to myocardial ischemia, or oxygen starvation, which is what causes angina or chest pain.
So even just being slightly tachycardic starts to compromise the heart's own fuel supply.
Wow.
Okay, now for another sort of extreme fact from the notes that really struck me. Where in the entire body do we find the most deoxygenated blood?
Ah, yes. That distinction goes to the blood collected in the coronary sinus. That's the large vein that collects almost all the venous blood from the heart muscle itself before dumping it back into the right atrium.
And why is it so deoxygenated there?
Because the heart muscle, the myocardium, is incredibly efficient at extracting oxygen.
Hmm.
It pulls out about 70 to 80% of the oxygen delivered to it by the coronary arteries.
70 to 80%. That's huge compared to other tissues.
It's massive. Most other tissues at rest extract maybe 25 to 30%. The heart is working nonstop, 247, so its baseline oxygen demand is already incredibly high. It's operating near maximal extraction all the time.
Okay, let's connect this back to the anatomy, particularly that posterior left atrium we mentioned earlier, sitting right in front of the esophagus. What happens clinically if the LA gets enlarged, say, from something like mitral stenosis?
Right. Mitral stenosis is when the mitral valve between the left atrium and left ventricle gets tight, stiff, narrowed. Blood backs up in the left atrium, pressure rises, and the LA starts to stretch and enlarge, often significantly.
And because of its position.
Because it sits right against the esophagus posteriorly, that enlarged LA can physically compress the esophagus, leading to difficulty swallowing, which we call dysphagia. Patients might complain that food feels like it's getting stuck. It's their heart causing swallowing problems.
That's one compression syndrome. Is there another common one?
Yes, there's a slightly more unusual one involving a nerve. If the LA enlargement is really significant, it can push upwards and compress the left recurrent laryngeal nerve.
Where does that nerve run?
It takes a peculiar path. It branches off the vagus nerve, leaps under the arch of the aorta, and then travels back up to supply the muscles of the left vocal cord. The enlarging LA can press on this nerve right where it loops under the aorta.
And compressing that nerve causes?
Hoarseness, a change in voice. This specific sign, hoarseness due to LA enlargement compressing the nerve, is known as Ortner syndrome. It's a really elegant example of how pathology in one specific heart chamber can manifest with symptoms you wouldn't immediately connect to the heart, like voice changes.
Structure dictating function or dysfunction. Okay, one last major area, coronary dominance and the electrical system. What defines dominance?
Coronary dominance refers to which main coronary artery gives rise to the posterior descending artery, or PDA. The PDA is important because it supplies blood to the inferior wall of the ventricles and often part of the posterior wall too.
And what's the most common pattern?
About 85% of people are right dominant. This means their right coronary artery, the RCA, gives off the PDA. And crucially, in that same 85% of individuals, the RCA also typically supplies the blood flow to the AV node.
The AV node, that's the electrical junction box coordinating the beat between the atria and ventricle.
Exactly. It's a critical relay station.
So, knowing that the RCA usually supplies both the inferior wall via the PDA and the AV node in most people, what's the clinical implication if someone has a heart attack caused by blocking the RCA?
Well, you anticipate two major problems. First, damage to the inferior wall of the heart, the muscle itself. But second, because the AV node's blood supply is compromised, you have a high risk of electrical problems. Like bradycardia, a dangerously slow heart rate, or various degrees of AV block, where the electrical signal from the atria gets delayed or completely blocked on its way to the ventricles. So an RCA infarct immediately makes clinicians watch closely for these conduction problems.
It really highlights how the plumbing directly impacts the wiring in most people.
Precisely.
We've covered a lot of ground here, from the heart's tilt making the RV vulnerable up front, down to the microscopic syncytium and those intercalated discs.
Right.
The counterintuitive diastolic coronary filling,
Yeah.
and then linking the LA's position to swallowing and voice problems.
Yeah. To quickly summarize the really key takeaways, that anterior position of the RV makes it trauma-prone. The posterior LA position explains those compression syndromes like dysphagia or Ortner's, and microscopically, that functional syncytium allows coordinated pumping. But the heart's huge oxygen demand, that 70–80% extraction, puts it constantly close to the edge, supply-wise.
And that brings us perfectly to our final thought for you, the listener, building directly on that oxygen extraction fact. We know the heart muscle is already pulling almost all the oxygen out of the blood it receives at rest.
It doesn't have much extraction reserve, unlike other tissues.
Exactly. So here's the question. If the heart's workload suddenly shoots up, say you break into a sprint, it needs drastically more oxygen immediately. But if it can't just extract more oxygen from the blood flowing through, how does the heart muscle possibly meet that sudden, massive increase in oxygen demand?
That's the million-dollar question for an organ that never truly rests.
And the answer, flowing right from what we've discussed, is that the heart's only significant option is to dramatically increase the flow of blood through the coronary arteries. Since it can't extract more O2 percentage-wise, it just needs way more blood delivered per minute.
Pure flow increase.
Pure flow increase. It achieves this incredibly rapidly through local autoregulation. Things like adenosine and nitric oxide are released by the working muscle cells, instantly dilating the coronary arterioles to boost flow. It's a demand-driven supply system operating constantly, showing just how specialized and, frankly, high stakes the heart's physiology really is.